Thank you, Bishop. State your name and who you're with and position on the bill in 2 minutes.
Yes. Excuse me. Thank you. My name is Bishop Michael F. Olson, and I serve as the Roman Catholic Bishop of the Diocese of Fort Worth, Texas, an area that covers 28 counties in North Texas. I'm testifying on behalf of the Texas Catholic Conference of Bishops in support of SB 1944. The Texas Advanced Directives Act's dispute resolution process protects patients and physicians by providing a fair and reasonable process to resolve disagreements regarding end-of-life care decisions. While this law is not often used, it is generally used appropriately and compassionately. Even with its advantages, however, some aspects of the TADA would benefit from more specificity and clarity. For this reason, the Texas Catholic Conference of Bishops and its Catholic Healthcare Association of Texas have sought reform of this act for more than a decade. The foundational Catholic principle of respecting the inherent dignity of human life from conception to natural death is at the heart of our call for access to ethically responsible health care. Pope St. John Paul II emphasized the clear and unambiguous right to life in his encyclical Evangelium Vitae, in which he affirmed that the sanctity of human life exists in every human being, regardless of age, stage of life, or disability, and specifically condemns euthanasia as a grave violation of the law of God. We maintain at the outset that all human life, no matter how disabled or critically ill, is of inherent dignity and incomparable worth. Thus, it is no less entitled to adequate health care. Our position takes a consistent and balanced approach to end-of-life care that equally respects the rights of patients in the natural process of dying and the integrity of the conscience of healthcare professionals providing their care. While illness and other circumstances can make life very difficult, they can never diminish the inestimable worth of each human life created by God. Life itself always has quality that can never be lost, and the inherent dignity of human life requires that we not cling to this life with excessive, burdensome, and oppressive treatments, for our ultimate destiny is eternal life with Christ in heaven. I will just close by just saying that as uncomfortable as the consideration of death may be, we must nonetheless prepare ourselves and our loved ones for the inevitability of the end of this beautiful but transitory life. Acceptance of natural death is neither euthanasia nor giving up on life, but can be an expression of profound Christian hope in the life that is to come. Thank you.
Thank you for that very much encouraging words, for sure. I guess, and it may be a philosophical debate to have, but if I understand the Catholic position correctly, and I've been in this subject matter for years now, you say that the physician's conscience and the patient's conscience, that is an equal footing.
No.
Okay.
All right. I'm saying that it's not a battle of autonomies. All right. There's not autonomous rights that somehow gets measured through a synthesis. The primary care and the primary stakeholder is the patient himself or herself. The physician has correlative responsibilities and rights in accord with his or her profession to care for life, to provide healing where appropriate. However, the obligation for them is scoped by what is going to assist and not give burden and suffering to the patient. So, for example, the patient does not have an absolute demand on the physician's talents as a technician, right? But rather relies on the physician for his or her talent and gifts as a healer and as a physician, appropriate to their not only science but practice.
And I very much appreciate it. And from the faith perspective, we recognize it's not an end but a beginning, right?
It's a transition, yes.
And I appreciate that very much.
Everyone Jesus ever healed died, except Lazarus, who died twice.
That's good. Under the bill, it speaks to a surrogate the surrogate would be chosen by the hospital. Is that correct?
My understanding is that it's usually it's the patient who's declared a surrogate, and according to this, in the conflict, I'm not clear on exactly the surrogate that's decided. This process takes place after the litigious aspect of the process doesn't kick in till till the conversations have gone on between patient, physician, their family, and the hospital. So it's and that's why we agree that 10 days is too short, and we're asking for an extension of 21 days.
Yeah, I appreciate that change. I think Senator Hughes' bill takes it completely off. But I appreciate members. Any questions?
I do.
Senator Seliger.
Thank you. Bishop Olson, should a surrogate be able to override a patient's express DNR?
Yes, I believe so. And the reason that is because of the prudential judgment that a surrogate makes on behalf of the patient's interests. Healthcare is a practice, and these decisions for end-of-life care, what is assessed as burdensome or not burdensome, are not delivered in an a priori way with a list of services that are necessarily imperatives to be given, but rather they're assessed and judged by the patient, by the patient's proxy, along with the physician. So if I were to ask you, would you like to be maintained on a ventilator? And you'd say, well, of course I do. And I say, and you also have late-stage cancer, and you are in intractable pain. Do you want it? Well, how am I going to know that before the case, before it happens? That's where the proxy comes in. So it's a discernment made by the circumstances. If you want, it's a philosophical question behind it. It's Kant or Aristotle or Aquinas. Now, I personally think Aquinas is right on this, in the sense that it's either teleology or deontology. Deontology says, that's the order, that's it. But teleology and virtue ethics understands the role of circumstances that can make a good action to become bad, but not a bad action to become good.
What happens in the case of a child who cannot have expressed wishes for DNR or sustenance or things like that? Kind of guide us through that view.
Well, I believe that it is the responsibility of the parents or guardians, first and foremost, to make those decisions on behalf of that child. Life does, that's their responsibility, their chief responsibility. Physicians have a responsibility to give an honest diagnosis with consultation, and then also to offer what care is helpful and not just burdensome.
Does that change when we get into a hospital owned by a municipality or one operated by an order in the Catholic Church?
No, the principle is morally acceptable.
Okay.
It's in principle, yes, it's in principle adheres. It's not just a matter of faith, it's a matter of right reason.
Okay. Thank you, Bishop. Thank you, Mr. Chairman.
Thank you.
Members, I've got the bill author here. He wants to ask some questions. But before that, are there any committee members? All right, Senator Hughes recognized for questions.
Thank you, Mr. Chairman. Thanks, Bishop. Thanks for being here and
Thank you.
walking us through these matters. I'm not Catholic, and I have some Catholic friends and Catholics I look up to greatly, and so I'm sure not an expert on the theology, so thank you for walking us through it. I've understood some concepts from other witnesses on this topic and similar bills, and so if we think about the patient's rights, if you will, and the physician's rights, we recognize that it would be wrong for us to force a physician to give care which she deems inappropriate. All things equal, looking at that by itself, we wouldn't want to deprive the physician of the right to practice medicine according to her conscience. We also wouldn't want to deprive the patient of her life. And so then my understanding is when we have a conflict of interest like that, we look at a number of factors. Which one was acquired first? Which one is more deeply held? And what would the consequences be if one of those rights had to yield to the other? And so then if we are proposing in a conflict like that, if we say that we would require the physician to give life-sustaining treatment for a period in order to preserve the patient's life, if we did that, we would be burdening the physician's right to practice medicine according to her conscience. If we go the other way and we allow the physician's medical decision to trump, then the patient loses her life. The physician is going to recover from not giving care exactly as they wanted. The patient's not going to recover from having been deprived of their life. Forgive me for my redneck version of that, but isn't that how that we balance those rights?
Well, no. In the short run of things, frankly speaking, is that you're dealing with in a relationship that's imbalanced by definition, because the physician has an understanding and knowledge. The conscience is not just simply based upon values, but by an objective medical standard. Hence, they're judged by a standard of care. And hence, in this bill also, there is the issue of consultation with other hospitals, with other places, a right to transfer. If the other hospitals, other places, long-term care facilities, as you mentioned, and other physicians say, no, we judge this differently by our standards, and we'll be glad to accept this patient and treat this patient. We don't understand on the objectives of basic medical care and practice, in the practical judgment that this is to be futile. We see it differently, and so the patient has right to that access to the other opinions of qualified, credible medical professionals.
So then, thank you. So in a case like that, a physician has made a decision of conscience, right, based on
conscience and professional judgment.
Okay,
yes.
And so we're saying that the physician's conscience decision should be able to trump the patient's conscience. The patient's decided that even with these burdens, I would rather live like this than not. And so we have two humans who've made conscience decisions based on their experience, one with a whole lot more to lose, respectfully, than the other.
Well,
why is the patient's conscience decision not valid in a situation like that? And it's a genuine question. I'm not trying to argue.
Oh, no, I understand. It's an excellent question that comes up in the most sensitive circumstances. It's not unlike a patient that comes in and demands hormonal treatment at the age of 13 or 14 because of transgender therapy. And a physician says to the patient and parents, I don't think this is right. I think it is morally unethical, and I'm not going to do this, and I think it's damaging. And the patient says, or their surrogate say, I want it. It's my right, and I really believe this to be the case. Well, what's the arbiter of that except a scientific understanding and a medical diagnosis, as well as it's always involved with basic values, hence the point of the responsibility or right to look for a transfer. So if a whole set of hospitals and other teams of physicians throughout the country say, we think that the doctors have a right assessment and what's being asked for is unreasonable, burdensome, and pain-giving, but then they say we're not going to take that patient. And so it's not the lack of treatment that is going to, in these cases, that is the underlying catalyst for a patient dying. It's the underlying symptom. It's the underlying. What kills them is whatever the ailment is that is debilitating them to an extent where they are in the process of dying.
Well, I recognize that, and our esteemed colleague in the layout talked about how we're just prolonging the inevitable. But isn't that true of all medical care? We're all terminal at some point, and barring the Lord Jesus appearing in the air and rapturing the church, we're all going to die at some point. And so absent medical care, absent life-sustaining treatment, wouldn't that be true of every one of us?
In a sense, even George Burns couldn't find another way out of this, right? However, terminal has a specific medical character to it. It means that this particular pathology that is affecting the patient, that is going to run its course, and within a period of 6 months, I believe, I'm not clear right now what the current standard of care is, will end the patient's life. From this, in other words, the organism of the patient's life, body, is not going to be able to recover, and what can be done next is either palliative medicine, can life-sustaining for quite a while, but as far as the alleviation of suffering is another question.
And along those lines, we think of this coming up in a terminal setting, but I'm sure you know that the law that we're debating does not limit this application to terminal. A physician can invoke this provision whether the patient's terminal. The law does not require him to be terminal, but we believe it should, but it does not.
Well, there are also chronic diseases. So you take the case of diabetes, all right? Now, diabetes can be treated a great deal by dialysis, but patients can determine after a while that this is too burdensome for me, because it is a very burdensome and they can decide to forego that. Now, is the patient terminal of that or not? No.
So the patient can make that decision?
Yes.
Amen.
In those cases.
Amen.
That's correct. However, in a case where there is excessive burdensome treatment, whether it's physical torture or also psychological repugnance, in the Catholic tradition, a patient or their surrogate can make that determination. The doctor can agree with it or not, in which case there's a right for transfer on that.
Well, thank you. And one more thing on the transfer. Again, 10 days is the current law, and the proposal in the bill that you're supporting would go from 10 days to 14 days.
The 21, I think, is what we've said.
Well, they're adding 7 days before. They're extending 48 hours to 7 days, then extending 10 days to 14 days. And I think testimony before the committee has been that families and patients don't realize what's at stake until they go to that ethics committee and they're told, okay, we're going to withdraw treatment. That's when the 10-day clock starts.
That's why the extended time.
That's when the 10-day clock starts. I'm glad we agree more time is necessary. And so do you have a sense for how we got to those numbers versus more or less?
How we got to those numbers?
The ones in the bill that you're testifying for.
I think that it seemed to be a measure of right judgment, of time to take in the widest amount of circumstances, the widest amount of situations that one can assess. My sense is, and my understanding in talking to healthcare professionals, hospitals, and also other patients, is that usually this is not an adversarial process. It's only till later when the time doesn't kick in until they've reached a point where it seems that further dialogue requires more, if you will, a legal stricture of time.
Okay. So,
the conversations are ongoing all the time with the patient and their physicians and their team of physicians.
Should be.
And their proxy. Well, it's good health care.
You bet. That's how it's supposed to work.
And I think I appreciated what you had to say earlier, because I think the rhetoric sometimes that there are hospitals or doctors that want to kill your patients is not helpful for a very nuanced and very delicate medical issue and human issue, quite literally life and death, that requires prudence and right reason and peace.
Well said. The testimony before this committee in previous sessions in this very room has been chilling, sworn testimony from patients. And when you hear that, you understand why folks get so excited about this. But thank you for walking me through this. I appreciate it. Thank you, Mr. Chairman.
You're very welcome.
Senator Hughes, just a quick, Senator Selgren.
Bishop, if I'm trying to ask you how many angels can dance on the head of a pin, please don't hesitate to say so. But a little while ago, you mentioned futility. And is futility a medical judgment, a judgment of faith? Is it a parental judgment?
I think it's all of the above.
Okay, thank you.
Sorry, Senator.
I'm
Senator
done.
Powell, do you have a question? Okay. I'll just leave it where I'm conflicted, to be perfectly honest. And these are, we're not showing everything because we're not capable, right?
Right.
So these are questions that maybe will be better answered when we all get our homecoming. But by definition, we're all terminal, right? We're all
In
gonna
the broadest,
pass.
ultimately, yes,
And I guess-
life is finite, yes.
Yes, it is, and that's why we pledge to the higher call of believing there's a better way.
Yes.
But faith, by definition, if it's true faith, it's not based on logic or science. Is that a fair statement?
It's not a Catholic statement.
Okay, all right, okay. Well, and I'm okay with that, and I don't mean to
Right.
ever
Well,
disrespect, but.
I mean, you're in my kitchen, you eat my cooking, I'll eat your kitchen, I'll eat your cooking.
And this is truly from a counter perspective, I guess.
Yeah, the Catholic tradition, Catholic tradition it's an intellectual tradition that involves faith, and then faith-seeking understanding, and then an anthropology and understanding of the human person. So faith is a mystery, not a riddle.
Right, and I appreciate that, and that is very clarifying in my mind, because I can't get where you guys are on certain levels on some of these issues, and that's just the bottom line, baseline is my faith isn't scientifically provable by human standards, nor is it supported by any human standard. So if my belief is I'm supposed to fight till the end with all I have on this side, then I believe I'm supposed to be the decision maker. Now, that said, I've had great counsel with a loved one in this past year.
Yeah.
And we all knew, honestly, probably prior to, even before my father-in-law knew, that it was numbered. There was a physician or two that said, you got 90 days from this point. The guy was walking and talking just fine. As COVID hit and some other things that interfered with that, it was almost to a day, pretty close to that day. Yeah. And the guy was 87 and never missed a beat and never took a pill. Perfect health at that point. So we were kind of shocked and dismayed, but as that time got closer, we knew, and honestly, I'm not sure he ever recognized it, but we sought counsel, and obviously he didn't want to be where he was going to end up if things had continued down that path. So I'm not anti that. I just want it to be that family and that individual's never. I don't know where we get to a surrogate that has that kind of support network. If you had told me under this bill, we're going to have a surrogate out here to make this decision for you because you as a family or you as a patient can't rationalize it in a way that makes sense to the medical profession, I can't go there. I can't get there.
I think I agree with you in the sense that these decisions are really made out of conversation and compassion, and also my experience in working with people who are dying, right, and their families, and are discerning these issues. Many times there are also unresolved family issues that are coming to the fore that require closure, if you will, sure, or in a more religious term, reconciliation and forgiveness.
And I don't disagree with any of that. I would also go back to your example of the transgender at 14 or 15 going and saying, I want to do this. And I'm not even sure what the Catholic position is on that. I don't care.
No, it's the short answer.
Thank you. I learned something a lot today. But that's distinctly different than someone that voluntarily is going into a situation that they have complete control of, say, please do this to me, versus an individual that is facing mortality at a very real level that didn't ask to be in that situation, that is looking to support groups to helpfully make
and what about the physician?
But that's a different, well, and I guess that's where we fundamentally different on this issue. It's the patient and the parent and the family support network's final decision. And that's just where I say it is, because I don't know what God's got planned for me tomorrow or the next 3 minutes.
How would you answer, though, the patient and physician that tells you that their conscience says they want euthanasia and assisted suicide. And the physician, how would you reason that? What's
Yeah,
different about that?
I guess it's just from my fundamental and these bills that come through here, I always lean on life
I
under
understand.
all circumstances.
It's of such
no matter,
great value.
No matter what that is, and I do agree with the Catholic faith that we have an obligation to help those folks, right? If we're going to birth them, we got to.
Yes.
We shouldn't raise them, and we shouldn't, but we should be a part of those networks. That for those that are not as fortunate, I agree with all of that wholeheartedly. But on this issue, when you have to make that call, I guess it's life, and that's where I'm conflicted because I respect
Yes.
folks like yourself immensely,
Thank you.
and
I
I'm
know
always
that.
learning. And this has been a good conversation for me, and I apologize to the members, but I needed to hear some of these conversations in this setting. So,
Thank
thank
you.
you, members. If there's no other questions, we'll let this guy off the hook.
Thank you
Thank
very
you.
much.